Next, I present our next speaker, a very passionate clinical cardiologist, Dr. Syed,
Thanks a
who
lot,
is
sir.
MRCP, and today we have a lot to learn from on the various scenarios of the DVT uh, in various clinical conditions. Now, Dr. Syed, please.
Thanks a lot, sir. Thanks a lot for Mr. Knight's introduction. So, yes. So, good evening, everybody. Today, my presentation's topic is DVT and pulmonary thromboembolism, and special approach to the DVT and PTE patient, that we should think beyond anticoagulation regarding these cases, and we should try to find out what is the reason behind DVT and pulmonary thromboembolism. So, I am not going to present any rare case here or any um, case which we don't encounter regularly in hospital. I believe that young doctor should be able to treat 90% of the diseases that he is encountering in the hospital in an excellent way, and few patient 5 to 10% that we have the specialist to treat that patient. But one should be expert in handling what we see regularly in hospital, and we should be able to find out and treat regular cases in an excellent way. Let's start my presentation. This is a clinical scenario based approach. These are the cases that I have seen in my clinical practice while working in different hospitals. So 55-year-old male patient, he was police constable by profession. He was non-diabetic, non-hypertensive, and he was recently diagnosed with pulmonary cox, and he was on anti-tuberculous therapy since 5 months. But since 1 month, he complained that he was not feeling well, and he was having malaise and lethargy. So he took leave from the police department, and he was in home since 1 week. But he was not definitely bedridden. He was used to walk in his home and do his daily activity limited in his home. And suddenly, in one night, he developed overnight swelling of his left lower limb. His left lower limb was red and painful, and it was swollen. So he was brought to hospital, and vitals in hospital, his pulse was 86, respiratory was 14 per minute, blood pressure 120 by 80, saturation was 98% on room air, and his investigation revealed that his hemoglobin was 5.4 gram percent, TLC count was 9800, platelets 2.5 lakhs. ECG revealed sinus rhythm with no STT changes, while bedside 2D echo done in the emergency room revealed that normal size cardiac chambers, no LVR WMA, good LV systolic function, with ejection fraction of 65%, and his IVC was normal and collapsing. So basically, there was no evidence of pulmonary thromboembolism in him. And we did a lower limb venous Doppler, and we found that there was acute deep venous thrombosis of the left lower limb veins. So this was quite unusual why he developed DVT, and we thought to search for the cause of DVT. So this patient has suffered acute DVT of left lower limb. There were no signs of pulmonary thromboembolism, but there is no obvious precipitating cause of DVT. Like, he was not actually bedridden, he didn't had any fracture, he didn't underwent any hip surgery, and he was not having any critical illness, like he was not in ICU in a bed. But this patient was anemic with hemoglobin of 5.4 gram percent. Was that a clue for cause of DVT? So medical gastroenterologist was involved because he was having iron deficiency anemia, to find cause of anemia. So we did upper GI endoscopy, and you can see in upper GI endoscopy we found that he had a large gastric ulcer, and we took biopsy of that ulcer, and biopsy of that ulcer revealed that he actually had a gastric cancer. So this was the reason behind his DVT. The underlying malignancy was causing his blood to become hypercoagulable, and this hypercoagulable blood led to development of DVT in this patient. So the UK NICE guideline advocate that if you have any patient who is above 40 years of age and he's having DVT, and there is no obvious precipitating cause of DVT like bedridden status or any fracture or any injury or any critical illness, then you should search for occult malignancy in those patients who are above 40 years of age. So take home message from this case is that DVT treatment is far beyond starting anticoagulation and putting patient on oral anticoagulation. DVT patient needs to be thoroughly evaluated to find cause of DVT. As in this case, occult malignancy was the cause. Common causes of DVT are immobilization, surgery, trauma, pregnancy, use of oral contraceptive pills or hormone replacement therapy in postmenopausal women, malignancy, antiphospholipid antibody syndrome in young ladies, heparin-induced thrombocytopenia, proliferative disorders, smoking, obesity, inflammatory bowel disease like ulcerative colitis, Crohn's disease. Although these patients have bloody diarrhea, but they are hypercoagulable, inflammatory bowel disease patients, pacemakers, central venous catheters, nephrotic syndromes. These are the causes. These we should search for these causes, and if we are able to treat this problem, then patient will not have recurrent DVT. Scenario 2 is 37-year-old lady. She was non-diabetic, non-hypertensive, and she went to Kedarnath Yatra in Kashmir, and she had road traffic accident there, and she had lots of faith on orthopedicians in Hyderabad. So she came all along from Kashmir to Hyderabad for surgery. So she was having. I was given consultation for fitness for non-cardiac surgery. She had excellent functional capacity before developing this fracture. Her echo ECG was fine, so I cleared her for surgery, and her surgery was uneventful. And she was put discharged on unfractionated heparin as a DVT prophylaxis, because at that time Clexane was costly, and the dabigatran was recently introduced, and we thought that it is better we give heparin as a DVT prophylaxis. And she was discharged in stable condition. And after 1 week, she came back to hospital, and I got a call that this lady has swollen limb, operated limb, and it was red and warm. So we showed to the surgeon, thinking is there is any infection at the fracture site, but the signs of infection were not there. TLC counts were normal, CRP was normal. So lower limb venous Doppler confirmed that DVT, and we were not sure. This lady is on unfractionated heparin. Why she developed deep venous thrombosis? So possibility of heparin-induced thrombocytopenia thrombosis was taken into consideration because she was exposed to heparin. So complete blood picture was sent, and it revealed thrombocytopenia. While we sent HIT antibodies, that is HIT antibodies, they came as positive in this patient. So in this patient, we stopped the heparin, and we treated this patient with fondoperinox. Later, her platelet count improved, DVT resolved. We initiated dabigatran as a anticoagulation protocol for her for 3 months, and this was the reason of DVT. Take home message is that if we are putting any patient on heparin, we should do daily CBP to see for platelet counts. If there is any unexplained thrombocytopenia, that can be marker of heparin induced thrombocytopenia, or in some patient heparin induced thrombocytopenia thrombosis also. And whenever HIT is diagnosed, we should use non-heparin anticoagulants like bivalirudin, ergotroban, fondoperinox, apixaban, rivaroxaban, dabigatran, danaparoid, and hip warfarin. And in India, we usually rampantly available is fondoperinox, apixaban, rivaroxaban, and dabigatran are easily available. Scenario 3 is 39-year-old male patient. He is non-diabetic, non-hypertensive. He suffered fracture neck of femur secondary to road traffic accident, and he was not that much financially strong. So in Hyderabad, they took patient to some local quack, and he told that if he apply these pattis, and we keep him on bed for 25 days, he will be all right. But unfortunately, after 25 days, he tried to walk, but he was unable to walk. Pain was there. So now he realized that he needs to go to hospital. So he was brought to hospital for fracture fixation, and I was given consultation to clear this patient for surgery for hip surgery. So when this patient I saw, he was having right-sided chest pain. He was breathless, and he was having complaint of palpitation since 3 days. His pulse was 117 beats per minute. Blood pressure was 110 by 70. Saturation was 92% on room air. ECG revealed sinus tachycardia with no STT changes, while echo revealed tachycardia during study, normal size cardiac chambers, no LVRWMA, and good LV systolic function. But something was wrong. This patient was having right-sided pleuritic chest pain, and he was breathless since the 3 days, and he was tachycardic. His SpO2 was 92%. So I saw his X-ray that was done in a surgical profile. I could see that there is right-sided opacity in the right base. So considering his unexplained tachycardia, tachypnea, saturation less than 94% on room air, and right-sided opacity in chest X-ray, he was prolonged bedridden for more than 25 days. We did D-dimer, it came as 4,500 nanogram per ml. So possibility of deep venous thrombosis leading to pulmonary thromboembolism was suspected, and bilateral lower limb venous Doppler as well as CT pulmonary angiogram was advised. And his CT pulmonary angiogram revealed that he had right-sided subsegmental pulmonary embolism along with pulmonary infarction. And this pulmonary infarction was responsible for his pleuritic chest pain, and pulmonary embolism were responsible for tachycardia and an unexplained hypoxia. And surprisingly, his left lower limb venous Doppler was negative for DVT, indicating that the whole of thrombus was embolized to the lungs. So management of this patient, as he was not vitally stable, so his surgery was deferred in view of DVT and pulmonary thromboembolism. This patient has to undergo surgery. That's why he has to be started on parenteral anticoagulation. So I started him on injection Clexane 60 mg BD as a treatment dose for pulmonary embolism. And as the Clexane started to act, his symptoms of chest pain resolved and tachycardia got settled. His saturation improved to 96% on room air. And after around 4 to 5 days of anticoagulation, his heart rate stabilized and his saturation improved, and he was symptomatically better. So I cleared this patient with high risk for surgery, and fortunately he underwent surgery, and it was all well. After surgery, I put this patient on Eliquis 10 mg BD for 7 days, followed by 5 mg BD for 3 months as a anticoagulation for unprovoked DVT due to bedridden status. So, learning points in this case is that early we fix the fracture, early ambulate the patient, chances of DVT and pulmonary embolism we reduce. Pulmonary thromboembolism can present as pleuritic chest pain too without hemodynamically instability. Clue can be unexplained sinus tachycardia only. The typical ECG that we say S1Q3 T3 is present in only 24% of cases. Most common finding in pulmonary embolism is sinus tachycardia. Absence of DVT in Doppler is not a proof that there is no pulmonary thromboembolism, because many times whole thrombus that have formed at the lower limb can get embolic to the pulmonary artery, causing pulmonary embolism. And 2D echo becomes abnormal only in hemodynamically significant pulmonary thromboembolism. Small PTE, there will not be any 2D echo change. So 2D echo is not a test that will rule out pulmonary thromboembolism. Your well score, your clinical suspicion, your vitals, all you have to consider to diagnose pulmonary thromboembolism. Immobility in a healthy patient can too lead to DVT in absence of medical comorbidities, even if it is as less as 3 days. In guidelines, it is said that if patient is immobile for even for 3 days without anticoagulation, he is a candidate to lower limb Doppler and D-dimer test, because immobility of 3 days also without any comorbidities in a young healthy patient can also lead to formation of DVT. Scenario 4, 64-year-old male patient, hypertensive diabetic. He suddenly developed swelling of his left leg. Doppler evaluation revealed DVT. So he was started on Clexane 60 mg BD as DVT prophylaxis, and the general physician sent me to rule out if there is any pulmonary embolism. So when I saw this patient, he was having no tachycardia, no hypoxia, no hypotension, ECG echo, no evidence of pulmonary thromboembolism. And he was elderly, 64-year-old, and he had unexplained DVT. So as I have said previously, we searched for malignancy. We sent tumor markers, PSA for prostate malignancy, that was negative. carcinoembryonic antigen for colon cancer, that was negative, alpha fetoprotein for liver malignancy, negative, CA19-9 for pancreatic, all negative. So we did CT chest, CT abdomen, and CT pelvis, CT pulmonary angiogram, and CT venography of the lower limb to search what is happening exactly. Are we missing any tumor anywhere, and how the veins of the lower limbs are there? We wanted to see that, and we found that this patient has left common iliac vein appears significantly thinned out, compressed, sandwiched between right common iliac artery and posteriorly by the bridging osteophytes at the level of L4 vertebra, seen as long segment narrowing of left common iliac vein, to consider possibility of May-Thurner syndrome. So this was a case of May-Thurner syndrome. You can see what is May-Thurner syndrome, what happens in that. Here, due to abnormal position of the great veins and great arteries in the pelvis, what happens? The left common iliac vein is compressed due to right iliac artery. You can see here, left common vein which is present posteriorly, it is getting compressed by right iliac artery. In between right iliac artery and the spine, it get compressed. As the vein gets compressed, the stasis happens in the left common iliac vein, and this stasis creates hypercoagulability and DVT develops. So this usually present in young patient, especially in the ladies, and recurrent acute left-sided iliofemoral deep venous thrombosis. 2 to 5% cases of DVT is due to May-Thurner syndrome. Female patient who are using oral contraceptive pills, who are having scoliosis, they usually have they should be suspected of DVT. How it is diagnosed? It is diagnosed with ultrasound Doppler or CT venography, magnetic resonance venography, or venography with intravascular ultrasound. Management is catheter-based thrombolysis followed by stent placement and subsequent anticoagulation as per DVT protocol. Warfarin is recommended as long-term anticoagulation for this patient. So this was an unusual case. So always we should try to find out what is the reason behind DVT. We had similar case in Apollo Hyderabad recently. A young patient developed DVT, and we found that he is actually having May-Thurner syndrome. And we did stenting to his left common iliac vein to prevent further formation of DVT. That can be catastrophic if he develops pulmonary embolism, and we have put him on anticoagulation with neuroral anticoagulation. One more interesting case I got to treat is that 70-year-old male patient. He was referred to me by a general practitioner after diagnosing that he had developed left lower limb DVT, and he already put patient on Eliquis, and he sent to me for cardiac evaluation. When I saw him in OPD, I realized that his ECG echo is normal, and clinically he is not having tachycardia or hypoxia, and there was no evidence of pulmonary embolism. And I advised them to continue Eliquis as a treatment for his DVT. But again, I was searching what is the cause of DVT. Asking question regarding malignancy: is there any weight loss? If there are any lumps and bumps in the body, is there any unexplained fever? Is there any loss of appetite? If there is any bleeding from natural orifices? But there was nothing to suggest malignancy. But I noted that patient was walking unusually slow, and there was loss of arm swing on both the arms, and his face was mask-like. So I suspected, is this patient having Parkinsonism? He looked 70 years, but his walking is very slow. Doesn't look like this is due to his age. So I asked first. I thought, is it idiopathic Parkinsonism? So I asked him since how long he is having slowness of movement. So attenders told that since only 2 months he is having slowness, and most of the time he is lying on the bed only. So there was no tremor, but his rigidity was more pronounced. Short history of slowness since 2 months, and only an absence of tremor was pointing away from idiopathic Parkinsonism. So in idiopathic Parkinsonism, there will be tremors in unilateral, but he was having no tremor, and he was having rigidity more than tremors. So I asked for drug history, and I found that he was actually a patient of schizoaffective disorder, and he was put on antipsychotic. I asked what antipsychotic he is taking. He was on medication called Down 2, and this is the medication risperidone. And risperidone is known to cause drug-induced Parkinsonism. So this patient developed drug-induced Parkinsonism, bradykinesia, and he was on bed most of the times. Due to this, he developed DVT. So I explained the same situation to the attenders, referred back them to the psychiatrist to change his antipsychotic medication to other medication which are not causing drug-induced Parkinsonism, and he was changed the medication to Carispec, which is a newer antipsychotic, and this patient improved and his Parkinsonism resolved, and he is better now. So just I wanted to give a message that whenever you see a patient, just don't write anticoagulation oral and IV. DVT is far more beyond anticoagulation. You have to see the patient in a generalist approach first, then you go to your specialist approach. Finding the problem of patient is important than treating the report of ultrasound, report of Doppler. So I have more slides regarding DVT and pulmonary embolism, and it will take more time. If sir allows, I can continue.
Yeah, at the off chair. Yeah, it's a uh, wonderful summary of the practical clinical cases managed day in and day out by Dr. Sab. Um, Very interesting thing is the hit heparin induced. Am I audible, doctor?
Yes, yes, sir. Yes, sir. Yes, sir.
Am I audible?
Yes, sir. Yes, sir. You are audible, sir. Yes, sir.
Okay, it's okay. Speaker. Am I audible, doctor?
Yes, sir. Yes, sir. You are audible, sir.
Yeah, yeah. So, heparin induced thrombocytopenia is more like an autoimmunity where there are antibodies against the platelets when you give heparin. And instead of the biggest paradox is what is heparin? Heparin is anticoagulant. You can stop that. Yeah. Heparin is anticoagulant. Low platelet count situation also you expect bleeding, right? In spite of thrombocytopenia, in spite of heparin, what the patient has in HIT, heparin-induced thrombocytopenia, is not a bleeding diathesis. Rather, it is a thrombotic state. So HIT is of two types, HIT type 1 and type 2. And in the HIT type 1, you need not stop the heparin. You can continue. But in HIT type 2, we generally need to stop the heparin. That's a very common experience that we get while using the heparin, and a lot of times small bleeds present. That's a very good case that has been presented. And second is you have shown us the complete florid radiological features of pulmonary embolism classically. One is called Westermarck's sign, and other is called Hampton's hump in pulmonary embolism. So whenever there's a pulmonary embolism, there is a subpleural infarct. So below the pleura, which typically presents like a triangular shadow, as what you can see here, which is called the Hampton's hump. And there will be a focal oligemia of the pulmonary vessels radiologically, which is called as the Westermarck sign. So those two are very classical, and which you are able to see in the radiograph. Then, as rightly said by Dr. Saab, that 2D echo is not most of the times helpful in pulmonary embolism unless there is a significant hemodynamic compromise. So this is one very interesting and important point to learn from the cardiologist, that whenever pulmonary embolism is there, there is a pulmonary hypertension. So what is the difference between systemic circulation and pulmonary circulation? Whenever hypoxia is there, systemic, there is a vasodilation. Whereas in pulmonary circulation, there is a vasoconstriction. That's the reason there's a pulmonary hypertension. So how do we know that there is a pulmonary hypertension when we do 2D echo? What is the parameter? We call it as RVSP, that is right ventricular systolic pressure. So whenever the pressure against which right ventricle need to pump, whenever there's a pulmonary hypertension is there, it need to use more pressure during the systole. So whether it is below 20, 20 to 40, above 40, we call mild, moderate, severe. RVSP is the parameter we need to look for in the 2D echo. So that is a second very interesting point. And third very interesting learning for me, as Dr. Syed said, is orthopedicians are afraid of putting heparin, but orthopedicians are the ones who create the greatest immobility. And that way, because of their timidity to anticoagulate the patient, they are one of the etiological factors in creating the DVT in the patients in the post-operative phase. So that is what we need to be very watchful about. And generally we call S1 Q3 T3. S in the lead one, S wave. S is a negative wave. Q3 in the lead 3, the negative wave is Q wave, and T inversion in lead 3. So it is characteristic feature. It is not obvious feature always, right? So typically after becoming a topper in post graduation in first year MD, we all used to talk a lot of theory, and slowly we were completely humbled by the patients every day. So we need to be happy with sinus tachycardia. So why pulmonary hypertension lead to sinus tachycardia? So when there's a pulmonary hypertension, the right ventricle is unable to pump into adequately into the pulmonary artery, right? So that will make the heart go into excessive rate, sinus tachycardia, which is enough to consider a possibility of pulmonary embolism. Lastly, I can never forget the nightmare I had in the pulmonary embolism. Dr. Syed gave me opportunity to recall is I was a second year postgraduate. So that time the patient had a severe pleuritic pain. So when there is a pleuritic pain, we took a radiograph to look for any pneumonia or any pulmonary pathology. Then we found effusion. So the costodiaphragmatic recesses are all full. So when there is an effusion, we did a tap, and it turned out to be a bloody tap. So bloody tap, hemorrhagic pleural effusion, because of the pulmonary embolism leading to infarct of the lung, lead to bloody tap. So when there is a bloody tap, what is the option you have to in a patient of pulmonary embolism with a pulmonary infarct? We need to thrombolize. But to thrombolize a patient who had a hemorrhagic effusion is a nightmare. But there is no other option because there is a severe pulmonary hypertension in the patient. So thrombolized. So when we thrombolized, the hemorrhage in the pleural effusion become almost like a sea. So I could not know what to do with that patient except to drain that sea of blood coming out of the pleural effusion by placing an intercostal drainage. Ultimately, patient survived, but that is one bloody night I spent with pulmonary embolism with hemorrhagic pleural effusion, but managing with thrombolysis, which is the no other option available in a patient. So thank you so much, Dr. Syed,
Thank you,
and
sir.
wonderful clinicians like you who are passionate to uh, teach and learn from every case are the need of the hour for many residents like us to learn. So thank you
Thanks a
once more.
lot, sir. Thanks a lot, sir. Thank you, sir. Thank you.
So every Friday,
Hearing this word from a personality like you is, I can't explain in words, sir. Thanks a lot, sir.
sure. So every week on Friday evening, 4 to 5, we have a clinical discussion session, and I love to see you every week with one very nice case from cardiology, and
Sure,
that
sir.
will be
Sure.
a true honor. Thank you.
Sure, sir. Sure.
Thank you
Thanks a
all
lot.
for attending. Yeah.
Thank you, sir.